Good morning, everyone, and welcome to PrevenTalk 3, a high-level discussion focused on advancing access to care for rare tumor risk syndromes, or RTRS, through strategic policy, economic approaches, and collaborative European action. My name is Alexis Strader, and I'm the Director of Policy and Research at the European Health Management Association, and I'll be your moderator today. Before we get started, I'd like to introduce you to the coordinator for the Preventable Project, Dr. Carla Oliveira, who would like to say a few words to kick us off. Over to you, Carla.
Thanks, Alexis. So it is a pleasure for me to be here today as the coordinator of the Preventable Project, to meet a lot of people that is interested in these sessions. These sessions actually are an opportunity to bring together experts, researchers, policymakers, and other stakeholders to share their knowledge, to inspire new collaborations, to discuss challenges. And actually, if you have missed the two previous PrevenTalks, they are in our website, so you can access them and the recordings and summaries of these discussions. So I just wish this discussion to be as fruitful as the two previous ones, and to wish the best luck to our speakers and moderators today, and thank EHMA and SPI for taking this further. Thanks a lot.
Sorry, I had technical difficulties. Could we go back to thank you, Dr. Oliveira. Rebecca, if you could go back to the agenda slide, please. Thank you. So we're thrilled to bring together a dynamic panel of experts representing the European Parliament, healthcare providers, academic networks, and EU-funded projects, all working at the forefront of rare disease policy and care. This webinar is part of the Preventable Project, as you know, and it's funded under Horizon Europe, and Preventable examines the clinical, social, and financial impact of prevention versus treatment in RTRS, working towards a more cost-effective, patient-centered approach to care across Europe. For today's PrevenTalk, we will kick it off first with a presentation from my colleague, Rebecca Evelyn Popp, and she will give an overview of RTRS care challenges and key policy recommendations. Then we'll move over to a moderated discussion with our esteemed guests, and then have a brief Q&A and close after that. So with that, I suggest to all of our attendees, if you have questions for our panelists at any time, you are welcome to put your questions in the Q&A function at the bottom of your screen. And please make sure to direct your question to the specific person that is for, if that's the case. Great. Okay, so moving on to frame today's discussion, I'm pleased to welcome Rebecca Evelyn Popp. She's a junior policy officer at EHMA, and Rebecca manages European Commission-funded projects focused on cancer prevention and treatment, and plays a key role in driving policy and stakeholder engagement under Preventable. So please join me in welcoming Rebecca to the virtual floor. Over to you, Rebecca.
Thank you, Alexis. My name is Rebecca. As Alexis mentioned, I'm working with European Health Management Association on the privately funded project Preventable. I've led the work on mapping RTRS care challenges and translating our findings into policy recommendations. In the next few minutes, I will walk you through what rare tumor risk syndromes are, what we have learned about the barriers that patients are facing, and what changes we need at the EU and national level to improve care and prevention. So let's begin. So rare tumor risk syndromes, also known as RTRS, are inherited conditions that significantly increase the risk of developing cancer, often early in life. Though they affect fewer than 5 in 10,000 people, their consequences are very serious. These syndromes often go undiagnosed due to their complexity and lack of awareness, which delays care and limitations and limits prevention. Economically, the impact is also substantial. Cancer costs the EU around 199 billion euros a year. Prevention in RTRS is not only clinically effective, but it's also cost-efficient investment in sustainable healthcare. So what are the barriers standing in the way of better care? That's what we explored in our SWOT analysis. So we have conducted a SWOT analysis, and for this analysis, we have conducted semi-structured interviews with specialists across 13 European countries to identify core strengths, weaknesses, opportunities, and threats in RTRS care pathways. The main challenges that we have found are as follows. First, there are systemic and clinical gaps, a lack of guidelines, uneven access to expertise, and limited pediatric and psychosocial care. Second, we see financial and policy barriers with no EU-wide standards and limited coverage for preventive services, especially for asymptomatic patients. Third, there is a missing shared digital infrastructure and coordination between research and policy. And finally, the burden on families is very high. They face delayed diagnosis, fragmented surveillance, and financial and emotional stress. These insights guided us to develop policy recommendations both on EU and national level. And I will start presenting you on the EU level, the short-term action that we are proposing. So we need a minimum reimbursement standards for RTRS-related services and funding for genetic counseling and testing. ERN and juries should be supported to develop interim care guidelines. Awareness and training must reach health professionals across the EU, and we urge the inclusion of RTRS in Horizon Europe research priorities. This laid the foundation for more structural changes, which we turn to next. And in the long term, RTRS must be integrated into EU cancer mission. We also need a Europe-wide patient registry and GDPR-compliant platforms to enable data sharing across countries. Cross-border collaboration and ERNs require stable and long-term funding. And finally, we must strengthen international RTRS research networks that can drive both innovation and system resilience. Now, let's take a closer look at what national governments can implement on short term. Nationally, RTRS should be included in cancer and rare disease strategies. Access to genetic counseling and surveillance need to expand, and screening guidelines should be harmonized. Insurance systems should prioritize RTRS care, and funding must be allocated for pediatric-focused services. Looking ahead, this national system also needs structural reinforcement. So on the long term, we recommend establishing national RTRS reference centers connected to ERN and juries. RTRS must be integrated into national registries and care pathways, and we must invest in psychosocial support networks for patients and families. Cross-sector collaboration should become the norm, and permanent public funding is essential to sustain preventive care models. With this national action in place, we also, of course, need a shared European vision to truly transform RTRS care. So moving together forward, we must strengthen EU-wide collaboration, prioritize prevention in national and European agendas, and support long-term funding for research, registries, and care. Projects like PrevenTalk must not operate in isolation, but align in a common effort to reduce cancer burden through shared knowledge and structure. To close, I want to leave you with a simple message. Prevention only works when care is accessible, coordinated, and supported through cross-border collaboration, ensuring that no RTRS patient is left behind. And I thank you very much for your attention, and I'm leaving the floor to Alexis. Thank you very much.
Thank you very much, Rebecca, for that insightful overview. It's very clear we need stronger mechanisms to bridge clinical research and health policy to truly improve access and equity for RTRS patients across Europe. So with that, very nice introduction and overview, I'd like to move on to the next part of our agenda, which is our panel discussion. So you'll see on the screen that we have our distinguished panelists. First, Dr. Romana Jerković, who is a member of the European Parliament and chair of the MEPs Against Cancer Group. Then we have Dr. Stefan Aretz, who is a hereditary tumor specialist and preventable representative. Next is Dr. Ignacio Blanco Guillermo, who is a representative from ERN Gentures and a specialist in rare disease care coordination. And Dr. Jana Votápková, who is an expert in health economics and cross-border healthcare representing the FLASH project. So I'll be moderating, but please also add in your questions using the Q&A function at any time. And we will make sure to, or do our best to try to get to those questions after the panel discussion. Thank you, Rebecca. For now, you can stop sharing your screen. Okay, so I would like to kick off the panel discussion first with MEP Jerković. MEP Jerković, can you please tell me or tell the audience what steps can be taken to ensure that the policy recommendations from projects like PrevenTalk are translated into concrete EU and national action? You're muted, MEP Jerković.
Sorry. Yeah. Okay, you hear me now. Thank you, Alexis. Thank you, Alexis. This is the main point. How to get from the policy recommendation to concrete action. That's something that we need. And you know how it goes. Before the Commission draft the legislative proposal, they open a public consultation on a certain topic. Very often the project partners, NGOs, umbrella organization and private sector, they all respond to these consultations and their input is taken on board by the Commission. Then once the Parliament starts drafting its position, the stakeholders approach to us, they approach to MEPs and they present their point of view and their recommendation. And the same happens once the Council takes over from the Parliament. And finally, thanks to this maybe, I don't know, slow process, but all the stakeholders have their part in creating a law or directive. However, maybe it is true that there is no well-structured and transparent mechanism which would evaluate, prioritize, and translate those policy recommendations into legislations. And one solution could be the establishment of a unit at the Commission with the task to review the output of the EU-funded projects like PrevenTalk. And the role of this unit could be to assess which policy recommendations are developed enough to inform legislative work. And that would certainly make the whole process much transparent, much more open and clearer. But let me tell you also this, my current concern is not so much the uptake of the policy recommendations. And I will give you an example. We have adopted the EU Beating Cancer Plan 4 years ago. We have also very clear Council's recommendations on screening program. But what we lack, or better said, what the member states lack, is the implementation of these policies and recommendations. And to be more clear, member states fail to meet the target set by the plan. That's my opinion. So the implementation is what we need to focus on, and multi-stakeholder EU projects with a good geographical representation can play a crucial role. Thank you.
Thank you very much, MEP Jerković. Very well said, and I couldn't agree more. While the process is quite complex, when the policy recommendations from consultation to implementation is quite long, there is at least opportunity to share these learnings. But as you pointed out with the Beating Cancer Plan, implementation is really where there is oftentimes a lack of follow-up in terms of implementation. And this is where we need to focus going forward to make sure that at the member state level, we can help support them in terms of the implementation of the recommendations we develop in projects like PrevenTalk. So thank you for that. If I may go to the next question, I'd like to hear from you. How can the EU use tools like the directives or recommendations to ensure more harmonized standards for early detection and care of RTRS across member states? So this is getting into more of the implementation aspect that you just spoke about.
Well, there is so much that can be done. I think we need to empower and extend the role of European reference networks, especially ER and Gentouris, which already has the expertise on RTRS. But the expertise alone is not enough. These networks must have stable funding and better integration into national health systems, and that way the knowledge they produce can reach all clinicians and patients, not just those in major centers of excellence. And talking about funding, let's not forget the power of funding as a policy tool. Through programs like EU for Health and Horizon Europe, we can directly support national reforms aimed at harmonizing care standards, investing in genomic infrastructure, and training healthcare professionals. But as you know, funding of these programs under the next MFF is under threat, and I pledge to use my voice as an MEP to advocate for more funding for health. I truly believe that wherever you live in Europe, everyone should have access to timely, safe, and high-quality care. That is not too much to ask.
Indeed, not too much to ask. And we're so glad that you are an advocate for funding and continued funding, because you're absolutely right, MEP Jerković. Right now, funding instruments like the MFF are under threat, and this is directly impacting projects and the work that we do in the Beating Cancer Plan, projects like Preventable, the work that these panelists are doing. So indeed, we need to continue them to bring this forward and remind policymakers that funding as a policy tool is absolutely a key aspect of this. So really appreciate it. My last question for you, MEP Jerković, is about how can RTRS be embedded in broader strategic frameworks such as Europe's Beating Cancer Plan?
Well, as you know, Europe Beating Cancer Plan is very good and very ambitious plan. But despite its strong attention on prevention, on screening and innovation, the specific need of patients with hereditary cancer syndromes like RTRS are missing. So what can we do to change that? First, I think we need to raise awareness about RTRS because visibility matters. If we don't explicitly include RTRS in the implementation and monitoring of the cancer plan, then we risk missing the opportunity to address their needs in a structured way. And that's what we need. Whatever it's true, whether it is true on targeted genetic screening programs, genomic registers, or support for families at risk, RTRS must be part of the broader conversation on cancer. Second, we must push for better integration between EU and national frameworks. Member states are currently, and that is very important, they are currently updating their cancer strategies in line with the EU recommendations, of course. And this is unique window where RTRS can be integrated at national level, but only if the EU provides strong guidance and incentives. For instance, the Commission could request that all national cancer plans include actions on genetic screening and rare hereditary syndromes. And finally, I think it is important to have a European strategy on rare diseases in order to ensure that rare conditions like RTRS are no longer addressed in silos, but recognized as structural priorities. And for me, it's about building a health system that doesn't only serve the majority, but one that protects the vulnerable, or one that listens to the unheard and invest in conditions that are often overlooked. And that is the kind of Europe I believe in, and that is the kind of political commitment we need moving forward.
Very well said, MEP Jerković. Thank you. What I heard is very important points. One, visibility matters. We need to continue to raise awareness. Two, this is a unique window right now with the updating the cancer strategies at the national level, but this means we need strong guidance and stop working in silos. So thank you. And I'm sure that the other panelists will have thoughts and comments on the points that you've raised here. So I will open the floor to other panelists to comment or provide any additional thoughts on the points raised by MEP Jerković, if you like.
Yeah, I think in particular the incentives are really important because usually all this work is done for free. In the European reference networks and others, it's very ambitious, and usually the few experts need all their enthusiasm to do all this on top of their already busy schedules, and so this of course result in a delay of everything, and so we need funding for all these activities, also for the Jardin initiatives who try to implement these achievements of the areas into the national healthcare systems. That cannot be done only on a voluntary basis, so that's clear. But of course there's a competition between other fields of medicine, but the focus should here more on this RTRS, of course.
I'm totally agree with Dr. Aretz. We cannot be working for free. We need, our work has to be recognized in somehow. Introducing our work in the national health system will help us to be in the frame and also to keep our enthusiasm forever. That's is important.
I just would like to add to the legislative discussion that Romana mentioned. Besides a coordination of national prevention plans, it's very important to coordinate these activities internationally. And as you said, accessibility of care should not be a luxury, right? So it's great that that countries coordinated within the country where care is kind of easily accessible, but it's in some areas of the country, most of the countries, particularly border areas, are affected by inaccessible care, and there is where primarily international cooperation comes into play.
Thank you for this. And indeed, yeah, this work that we're doing for free, it's not recognized. And also, making sure to address the areas or the people that are have less access or intermittent access to care, and making sure that our strategies support them as well. So thank you. Dr. Blanco, I'd like to direct some questions to you, if I may. First, as a representative of ERN Gentores, how can ERNs contribute to the standardization of RTRS care across Europe?
Okay, thanks a lot for giving me the opportunity to participate in this webinar. What we are doing as much as we could in order to standardize care for RTRS syndromes. We are trying to develop, or we are developing, consensus guidelines. We have a lot of expert panels from our member states, and we try to gather the evidence-based consensus in order to have these guidelines. But not only guidelines, we try to create care pathways. We put together our intentions and to identify, in order to identify and to define the optimal diagnostic tools, treatments, and follow-up procedures. We are putting these care pathways in our web page and translate to the different languages, because this is another problem in Europe. And we think that in that way we will be able to improve the care of patients. But also we are doing activities in order to improve the knowledge about RTRS in Europe. We organize training models, workshops, webinars, because we have the feeling that we need to increase the knowledge of our health professionals in Europe. We also try to establish quality standards for the work that we are doing. And we're thinking if we should also try to introduce accreditation processes in order to define these specific centers to deal with RTRS. We also we have found a problem that is we have not enough data for these rare syndromes, and we need to establish, and we have established some registries, and also we have defined some data collection tools in order to share knowledge among all centers. Probably, as a last point, I will say that we are trying to promote research and evidence generation. We have the knowledge, but we have to prove that this knowledge is changing quality of life of patients. And for that, we are trying to promote research in the clinical side.
Indeed, you covered a lot of ground there, Dr. Blanco. Thank you. You're doing so much: consensus guidelines, identifying the optimal diagnostic tools and treatments, translating all of this into other languages, activities, considering accreditation processes, collecting data and research. And you hit on something that's really big in the Preventable project is data, because we are doing, indeed, we're facing this as we're collecting data in the project, and it is quite a challenge. And I'm sure the other panelists will discuss this, especially Dr. Aretz. But I would like to follow up with a question related to, you talk about consensus guidelines, so you all are developing this. When it comes to policy recommendations from the EU, how does ERN Gentourist react to these recommendations, and that relate specifically to RTRS across member states?
You make a good point. How we react. We face with all the bureaucratic problems that we have. There are a lot of complex administrative procedures that they delay decision-making process and implementation of these guidelines. We also face with some of lack of familiarity of understanding these RTRS diseases. And probably everyone knows that we have different policies and priorities, but not only in Europe, national policies, regional policies, local policies. we face with this bureaucratic problem. We as a professionals, we have the knowledge, we have the expertise, but we got with this big problem in order to translate it. Resources, we already say, we have a very insufficient funding. We have not enough personnel. Probably we have no the best infrastructures that we need. The healthcare in many countries is still very fragmented. It's very difficult to offer the whole cover that a patient with a rare syndrome needs. And also legal and regulatory barriers. Every single country has their specific regulatory barriers. And we have to face with this problem as a scientifics, as health professionals.
It's complex, Dr. Blanco, is what I'm hearing, and the barriers are numerous, but we do work hard to try to overcome them. Resources, bureaucracy, lack of personnel, legal hurdles, regulatory, all of this we're facing in it. And when at the end of the day, we're doing our best to provide the best level of care for patients. So thank you for your insights, and just going to open to the other panelists in case you have comments or questions for Dr. Blanco. Otherwise, we can move on to Dr. Aretz. Thanks for joining, Dr. Aretz. So for you, I'd like to hear, how does the Preventable Project generate real-world data? This is something that Dr. Blanco was talking about, the need for data. How does the project generate data, and how is this data going to help strengthen the case for prevention in hereditary cancer syndrome?
Yeah, that's a real problem, of course. So real-world clinical data from the patients, in particular those that document the long-term course of the disease, are of course extremely important to address different research questions that are important for care regarding diagnostics, prevention, therapy. But as we know, it's difficult to get them, it's difficult to share them, and usually the available clinical data are really incomplete. So that's why one of the main tasks of Preventable is the attempt to do a systematic collection of as many clinical retrospective data as possible from as many RTRS patients as possible by our clinical partners. There are at least 9 expert centers, and that means finally from the local health information systems of the participating specialized centers, where those patients hopefully get long-term specialized care. That's not easy, but in some centers at least there is a long-term care, and to have a quite complete set of data. In others it's not. For instance, in Germany the landscape is very much more fragmented, so patients can be treated at specialized centers, by some only for parts of their life. The records are distributed among regional hospitals, single physicians, and of course, according to the rules, these data can be disposed after a certain period of time, so they're just thrown away and are lost for the research field. So beside of this, some of our centers try, in addition, to actively recruit patients, more patients on a national level, just to increase the number of patients. And we also try to recontact our known patients to get informed consent to actively contact hospitals and physicians to close data gaps, to make it more complete. But of course, even with this approach, we cannot overcome the general, more system-based limitations we have in our system. So this is the clinical data are stored in a decentralized way, often paper-based at the moment. And so this may change, hopefully, in the near future, when the electronic healthcare records are being more available than they are, at least actually in Germany. And of course, we have some hopes that there are less strict rules for data exchange, for instance, opt-out solutions, so within the planned European health data space. So there's some hope of things that also policymakers recognize that the exchange of data is the basis for improving research in this field. But at the moment, actually, we are really faced with a lot of limitations.
Indeed. Thanks, Dr. Aretz. I think a lot of us are hopeful that the launch of the not the launch, but the EHDS and the electronic health records coming into play recently is going to make a big difference in terms of data availability and what we can use in order to have better visibility and fill some of those data gaps, as you mentioned. So indeed, there are a lot of challenges, and I appreciate you walking us through the approaches that we've been using in the PrevenTalk project, because it sounds easy, but it's definitely not. So contacting people to get more information, contacting hospitals, it's quite a complex web of work that you have to do as part of this. So I appreciate that. I would also like to hear from you, from your perspective, about reimbursement challenges. So this is pivoting a bit from data, but also I'd like to understand what are the challenges that you've encountered when delivering genetic testing and surveillance for RTRS?
Yeah, that's really a challenge as well. At least partly, there are for sure huge differences among countries. So it's always different. But in Germany, for instance, we have unfortunately two kind of healthcare instances: the private and the statutory health insurance. That's a problem. So on the one hand, of course, we have all these surveillance and preventive recommendations, which are published by an experts group or even published in high-level national, international guidelines. But on the other hand, these recommended measures and procedures are almost never included in the mandatory list of measures where the costs have to be reimbursed by the insurance company. So usually nothing of this is included, in Germany at least, in the obligatory scope of service of the insurance companies. We just have a few contracts for specialized care for the common TRS, so that's, for instance, hereditary breast and ovarian cancer, and those were negotiated between university expert centers and the insurance companies, but that's just for the minority of patients. And so the consequence is, in reality, that in particular for the private insurance, we often have to submit justifications and an estimate of costs, and then hope that the insurance will accept it. Often these requests will be refused. So then the physicians have the option, of course, let's say, to invent other plausible medical indications to conduct a specific procedure, such as a colonoscopy. And that's, of course, unsatisfactory. And so everything depends on the concession of the insurance company. Reasons for this are, I think, one main reason is that until recently, at least, there is really limited awareness of rare conditions in general in the healthcare system. There are not enough and powerful stakeholder groups. And the other issue, of course, is in Germany, for instance, we have a national board that defines which measures should be included in the catalog of reimbursed medical procedures. And of course, the decisions, what is included and not, is particularly dependent on the available medical evidence. And this is limited. We have often just expert consensus, and that is not the level of evidence which we usually regard as gold standard. But this is in contrast to common conditions. It's not possible to reach this level for the rare. So we need other ways to describe sufficient evidence. So that are one of the reasons maybe that is not included in all these reimbursement strategies. Yeah.
Dr. Blanco, it looks like you would like to come in here on what Dr. Aretz has said.
Yes, I totally agree with Dr. Aretz, but I will like to raise another point, because we are dealing with healthy people. Rare tumor risk syndromes identify people who is healthy that has an increased risk to develop a disease. And this changed completely the way that we are giving healthcare in many countries in Europe. Our healthcare system is dedicated to people who has a disease. Now we are trying to change the natural history of the disease, identifying people that is okay, but has a lot of risk of have a disease. And we have to modify things, and reimbursement has to be in a different way also, because we have to plan treatment or new procedures for healthy people.
Yeah, it's a really important point. We really have to change the mindset and make a shift from therapeutic to preventive medicine. Huh? And in particular, the private insurance, but also the others, they have the attitude, we just spend money to treat patients. So they expect ill patient and then everything is fine. But when you want to prevent and the patient is healthy, then you get these problems. It's a way of thinking. Yeah. So in Germany, for instance, in our national plans, it is described that we should shift from treatment to preventive measures, but in reality, this is not implemented. So there are a lot of barriers against this. That's true.
I'm new to RTRS. It's actually my first encounter with this kind of discussion. So I would like to make sure whether we are talking about changes in probabilities primarily, right? About getting cancer and not getting cancer. So the person who has the genetics for RTRS has a higher probability to develop cancer, right? And once the situation happens, then he like the change from 0 to 1 then behaves exactly the same as with the person with lower probability, but eventually ending up with cancer, right? Or can there happen also really like rare types of treatment for these RTRS people? Like really, as you have like rare diseases that are treated only in selected centers where there are a few of them in Europe and stuff like that, or are they treated by traditional types of treatment?
The good thing, let's say the good thing is also these are rare tumor risk syndromes. The majority of tumors these people may get are common cancers, and usually they're treated exactly in the same manner. There are exceptions, of course, but usually they're treated in the same manner as the sporadic type of cancer. That makes it easier in this way. Yeah, but of course there are also very, very rare and special cancers where it is recommended to go to a certain specialized center where surgeons and others are really familiar with this and they have a certain number that they have treated to really get common with this. Yeah.
I see. So in this respect, we could, if we catch the RTRS people in the society, then we could easily plan healthcare resources for the future. And if we include this into the reimbursement mechanism, or like how the funds are weighted among health insurance funds, then those with these predisposition would be treated differently within the system, right? So basically, if it was well captured, if the people were well captured, then the society would actually save resources.
That's the main aim of the whole preventable project.
Yeah, it's actually about planning resources for the future, if I get it right. Right?
Yeah. That's the main objective of preventable, to demonstrate. Hopefully, we are not yet there. The analyses are still ongoing, but we try to find out if the costs for prevention are lower than the costs for treating cancers, or advanced cancers, I have to say. So this cost efficiency analysis is a very important thing because it creates a lot of new evidence to hopefully also convince policymakers and other responsible persons in the healthcare system that even from a financial point of view, to save resources, it's better to spend resources, money into prevention strategies or preventive strategies compared to just let the patients get advanced cancers. Yeah.
That's
Very
one
good.
point. And
Yeah.
the other point that comes to my mind is planning of resources, because you're playing with probabilities.
Yeah.
So you could plan resources for the healthcare system as such, because you know what the probability is. You can prevent the probability to some extent, but you cannot prevent it fully.
Yeah, that's definitely true, yes.
Dr. Blanco, it looks like you wanted to come in here as well.
Yes, I want to raise 2 points. One is, as Dr. Aretz say, when a patient with a RTRS has a cancer, we used to use the same procedures to treat the cancer. However, as we know the background of the patients, we can at the same time to define a new way to have treatment and prevention at the same time. And for that, for example, if a patient with Lynch syndrome is diagnosed with a colon cancer, we can treat the colon cancer, but also we can prevent for new cancers to come. And another point is that using the knowledge, identifying RTRS people, we can define different risk populations and concentrate some efforts in people with high risk. And this is what PrevenTalk will try to demonstrate, that in long term, this save money to the community, because people with high risk are more susceptible to changes with good prevention actions. That's okay.
Thank you. Thanks for that clarification and further detail, Dr. Blanco, because indeed what I'm hearing put in different ways is the need for this mindset shift to preventive medicine, especially for those who are especially at especially high risk of developing RTRS, because one, it's for the patient's benefit, but also for the benefit of the system in terms of cost effectiveness. Well, that's what we're trying to show in Preventable, which is not so easy, but that is definitely one of the main objectives. So with that, we're getting close to time, and I want to make sure to have time to talk to Dr. Votápková. So I'm going to shift attention to you, Dr. Votápková, and because I'd like to hear from you more about your work on the FLASH project and understand the work you're doing around patient mobility across borders within the EU. This is something where we discuss often in our policy recommendations for Preventable, but I'd like to hear from your perspective. What were some of the most unexpected structural or administrative barriers faced by patients seeking treatment abroad? And how could the insights you have collected in your project help our project in Preventable?
Well, before we started solving the FLASH project, we were actually aware of the barriers that are out there regarding cross-border healthcare. So we were not really surprised by that. But within the FLASH project, we aim to find ways how to increase accessibility of healthcare in inaccessible areas, which are primarily border areas in most of the European countries. We concentrate on the area of the Czech-German border, but you could easily generalize it to any other two bordering European countries. Well, what the problem is in cross-border care is, on one hand, that based on the principle of subsidiarity, healthcare is is left as a national competence. It is designed to protect national resources, but inaccessible areas like border areas come to the problem. There are only a couple of ways how you can get treatment in another member state outside of your origin, and that is your blue your EHIC card when you travel to another member state for other purposes than healthcare. So you say you travel for business, holidays. So that's one thing. Or if you travel for the purposes of healthcare, you can ask your health insurance fund for permission prior to traveling there. And if you get the permission, your costs are fully reimbursed. You are only subject to user charges as the national of the other country. But there are a number of limitations. Basically, the care cannot be timely accessible in your home country, which often happens, and you can see it on European data. There is not much cross-border travels on S2 documents, so on the a priori permissions. And there is another way how you can receive treatment in another member state, and that is according to the directive of the European Commission regarding patient rights in healthcare. And that is that you travel to the other country, you pay everything out of pocket, and then ask for reimbursement to your insurance fund afterwards, but you get payment, you get refunds only up to the costs that are usually in your country. And there is where the problem arises in our case. In the countries with different price levels, so say the Czech Republic and Germany, the people who have not much accessible care in their home country in the Czech Republic, they live in the border area, and they have their closer, like they have a German hospital 10 minutes away from their house. They can go there, and the Czech hospital would be like an hour and a half away, or maybe also separated by mountains. Geography plays a deterministic role. So then, for this 10 minutes, for this hospital, which is 10 minutes away, you cannot go there because for the purposes, based on the European legislation, you are using a planned care. Although you have an acute state, but it happened in your home country, but for the purposes of care, you are actually crossing the border to receive care, right? So this is where the problem arises. The second point that that is a huge problem is the differences in the DRG systems. The Czech and the German DRG systems are differently set up, so you cannot easily say what the price difference between appendicitis surgery in Germany or the Czech Republic is. Because you just cannot take two surgeries, or you can one from Germany and one from the Czech Republic, because they are differently coded. They include different procedures, right? So what we are trying to do in the horizon is that we are trying to compare the RG systems and define price differences between hospitalizations between two DRG systems.
Got it. Right. Thanks. No, just for our audience members for their information to understand that about these different price systems, they may not be aware, but procedures are priced differently in each country, and this affects the ability to access cross-border care. So indeed, but you also talk about geographic issues, and that it's much easier to access cross-border care. The complexity is there. We're seeing that. So very briefly, because we do have a question in the Q&A, but very briefly, could you build on this to share with us in a minute or two, what are the mechanisms that could be introduced to ease access to care abroad, specialized care abroad, particularly for patients like RTRS patients, for requiring long-term or complex services?
Well, for RTRS patients, if we talk about like traditional treatments within the system, not rare diseases, this becomes an issue, sort of, because it would be exactly the case of planned care. And you can use planned care only using the two possibilities, either the regulation or the directive regime. A coordination of the system and the possibility to cooperate between the two healthcare systems would definitely optimize resources on both sides of the country, but both sides of the border. But
sorry, hold that thought. I just wanted to thank MEP Jerković. She just had to drop off to go to another call, so I just wanted to thank her for joining us today. Thank you, MEP Jerković, and wish you a good rest of your day. Sorry, I didn't mean to interrupt you, Dr. Votápková. I just wanted to say goodbye to her. So please continue.
No problem. So yes, a coordination would optimize resources on both sides of the border, because based on the freedoms of the European Union, labor, so physicians, nurses usually work in the richer or the country with a higher purchasing power parity, but the patients cannot go there to receive care. So such a coordination would definitely help, but this is not what is going to really happen at the EU level, I think. Thus, national initiatives have to take place. For example, based on our project, we have reached part of the amendment of the Czech health insurance law, such that Czech health insurance funds can now contract providers in a different country, whether they are if they consider it good and appropriate. But the question is whether they will actually do it or not, right? Because the headquarters of the health insurance funds are usually seated in the center of the country, which do not have accessibility issues, right, that much. And even the border areas fulfill the accessibility legislative limits that are set up by law. But technical accessibility becomes an issue. For example, if the roads are icy and you have to cross hills, you may eventually not be able to get to the hospital in your home country. But you can get to the hospital in the other country if you do not have to cross the border, the
Dr.
mountains, right?
Votápková, I'm so sorry. This is all the time we have today. Unfortunately, we've reached the top of the hour. I know all of you could speak for many hours on these topics. I see your passion and enthusiasm, and I thank you so much for being here today. I do want to recognize we did have a question in the Q&A, and to this person who asked about the JARC initiative and the Preventable Consortium. Unfortunately, we will not have time to answer your question, but we could certainly ask our panelists to write an answer to you through the Q&A if that's possible, just to make sure that we recognize that and we appreciate your contribution to the conversation. But with that, we will have to close for today. So I want to thank you all again to our speakers. Thank you also to Rebecca for her presentation earlier. And we have a feedback question for participants, for audience members. So we'll put that up on the screen so you can share your feedback, please. We also recorded this webinar, so we'll be made available to you shortly on our YouTube channel. So please do share with your networks for those that were not able to join today. And lastly, on behalf of the Preventable Consortium and EHMA, I want to encourage you to stay connected, and you can do this through our different social media channels. So please do follow us on LinkedIn, X, Instagram, Facebook, sign up for our newsletter, and help us continue to advocate for our RTRS care. And thank you again very much, and have a great rest of your day.